everyone, I'm Charlotte Marquis. I'm a board certified veterinary anesthesiologist, and today I'm going to be talking to you all about autotransfusion part 3. This is open system autotransfusion. So in the first two lectures, we talked about theory, and then we talked about how to do a closed system autotransfusion. So now I want to show you the two different methods that I use on the clinic floor in order to accomplish open system autotransfusion. So what is it? So open system autotransfusion is when we are taking blood from somewhere and the body cavity is being opened. Usually this is by the surgeon that you are working with or the doctor you're working with, and we are taking the blood and putting it back into the patient's blood vessels. So that being said, who is going to end up being a good candidate for this? So kind of goes without saying, if it's open, the body cavity has to be opened. This is going to be mostly for surgical patients. So we are doing surgery on the chest, we're doing surgery on the abdomen, and there is a collection of blood there that the patient is really in need of having. Now, there are two different types that I use, and depending on the size of the patient and the size of the effusion, we are going to make the call about whether we use something called the 2-syringe technique, or we put the fluid, the blood, into sterile ETO gassed suction buckets. So if you have a small patient, maybe it's less than 10 kilos, or you have a patient that has maybe less than 250 mils of blood in their body cavity, the 2-syringe technique is going to be a good option for you. The reason why I like this for small patients is that it will not take you that much time if the effusion is small. If we think about 240, 250 mils, that's, 4 or 5 syringes of a 60 mil syringe, so not that much time to do. But if your patient is much larger, if you have a really big dog, if you have a super traumatic injury, big distended belly or chest, this is when you're going to need to use the suction canisters in order to accomplish that. Because if you think about it, with 2-syringe technique, we're going to put it into these syringes, so 60 mils is all it takes at one time. So that's good for a small patient. But if you have a large patient, if you have something that's, greater than 10 kilos or it has a huge effusion, this is going to be the fastest way to get the blood out of the body and then capped off to keep it nice and clean in order to get that prepared for delivery back to the patient. So what are you going to need in order to get this done? Just gonna pull something from the side of the camera here. So I usually prefer to work off of some type of sterile quarter drape or sterile table drape. So you can have a wheeling stand with you. You can put this on a prep table. You just want to try to make sure the area is as clean as possible, maintaining asepsis the absolute best way that you can. Sterile gloves. So again, if you are transferring a culture medium, you're transferring blood somewhere, I would strongly recommend the use of sterile gloves. So for the 2-syringe technique, I like 2 types of 60 mil syringes. I like the catheter tip 60s and I like the luer lock 60s. So the reason why you need both of these is because it is going to take much less time to get fluid through this very large tip here. And then you can put it in here. You could certainly cut out the middleman and just do one of these, but I will say from personal experience, it's very hard to aspirate blood from the abdomen with this tiny little luer lock 60 because the mesentery and the omentum usually gets trapped in there. So this is how we would do it. Let's see, what else do we need? A fluid extension set. So if you are doing the 2-syringe technique, you're going to take it from the belly to the catheter tip to the luer lock. And then the luer lock gets attached here and the blood goes through the extension set and an 18 micron filter. This attaches to the patient and you just bolus that blood right back into the patient. Now, what else would we need here? If you are doing a large volume effusion, you should also have sterile suction tubing and ethylene oxide gassed or sterilized suction buckets. Because we're trying to maintain asepsis the best possible way we can, I would strongly recommend the use of gas buckets instead of just a bucket that's sitting on the shelf. You want to try to eliminate the possibility of bacterial contamination in any way that you are able. So For purposes of demonstration and for ease on the eyes, I'm just going to remove some of these things from my table before I demonstrate the 2-syringe technique. So I'm going to pretend here for the purposes of today that this is my patient with their blood in their belly or blood in their chest. It's very deoxygenated. This patient needs lots of help, okay? So I'll have this. Now, with the 2-syringe technique, you're usually going to be working with at least one other person. So that might be your surgeon or your doctor who is operating on the patient. And then you are the technician, doctor, whoever, who is providing maybe anesthetic care to that patient. So I'm going to be both of those people today, but I just want to show you how like the physics of this works. So what I do is that I'll usually open 5 or 6 on the table, on the surgeon's operating table for them. So that way they can just keep doing that and handing that to me. I'll open up 1 or 2 of these for myself. I'll reuse these when I take the blood from them, and then the surgeons will throw away this, but you won't throw away this until you're done with the transfusion, if that makes sense. So the surgeon's going to open up the belly or the patient's chest, and they are going to use, sometimes we make a mess, that happens. They are going to use the catheter tip 60 to collect the blood, and they are going to hand it to a gloved assistant, and that's going to be you. They can hand it to you and you can take it, or they can hold it upside down. You just get your Luer Lock 60 underneath it. You do not need to apply pressure. And then without pushing down on the catheter tip 60, you can suck that blood out of the syringe. And at this point, the surgeon can kind of toss this one. We'll pretend that's gone away. And you have this at your disposal. The next thing that I do is that I have my extension set with my little filter on the end. This is going to go to the patient's IV catheter, and this end is going to be what I'm working with. Again, try to keep it on your sterile drape the best you possibly can. And now at this point, I'm able, and you can see that fluid kind of traveling through there, yeah? There we go. We'll pretend that's blood. And now you can take blood that was aspirated from the abdomen and give that back to the patient. Now, one of the disadvantages of this particular system is that it can be a little more tricky to apply anticoagulant. Generally speaking, for every 1 liter of blood that you are providing, you should be giving around 140 mils of citrated anticoagulant solution. It's just based on the ratio that is provided in some of our most common blood storage bags. So I certainly recommend the use of it. You can always calculate that ratio and give that to the patient. And again, the community's kind of split still on, do we do it or do we not? My thought process is that if you are unsure if there's active bleeding, and it's really hard to find out, I would recommend the use of anticoagulant. So that is the 2-syringe technique. Just going to clean up a little bit here, and then we will move on to the use of suction buckets. So the use of suction buckets is a modification of the open system autotransfusion. So the suction bucket is a great idea when you have a very big patient. If you think they're going to have liters and liters of effusion, this is really what you want, because all you need to do is ask the surgeons or the doctor to get that fluid into the bucket, and then you can close up the bucket. And kind of gradually at a time, you can take that fluid and give it back to the patient. So I'm going to move my patient's abdomen off the drape here. So we have a gassed bucket. I unwrapped it just prior to surgery. The surgeons got the blood in there, and I closed everything up just to try to keep contamination to a minimum, the very best that I can. The next thing that I'm going to need for this is, we've talked about how anticoagulant is important. I like blood collection bags, but hey, if you can't get those, you can gas fluid therapy bags and you can add anticoagulant to them. So remember, it's 140 per 1,000 mils of collected fluid. So there we go. We're just going to keep this up here, and then we'll get organized for the suction bucket. So the most that I've ever done with a suction bucket was 5.5 liters. It did take a long time, but that patient did survive. So I think, at least in that situation, it was what we wanted. Okay, so let's get this on here. Perfect. So you have your gas bucket, you have your collection bag. On my collection bag here, I have a blood administration set with a 200 micron filter. I also have a fluid therapy giving set. This is just so I can get it from one place to another. And then I have my catheter tip and my Luer Lock 16. And there's a little 3-way stopcock on the end here. That's just so I can attach things and just like keep going here. Okay, so all I'm gonna do here is with my sterile gloves on top of my drape here, this usually fits in quite nicely here. I'm gonna just take blood from one place to another, turn it upside down, and again, I don't even need to put any pressure on it. I just can take it out like this. I will say, just because there are gonna be drips of blood because you're working with it, it's not at all uncommon to create a mess. So get some lap pads, get some towels, wear your gloves, wash your hands. It's gonna get messy. But that's surgery, isn't it? So now, if you're looking a little carefully, and I'll take my bucket out of the way here, that's my patient's bucket, is that the blood has gone from the bucket into the syringe and has now gone into the bag. And I could just keep doing this all the live long day. And the thing is, this is much faster with multiple people, but it is absolutely possible to do this as a sole surgeon. So if you are either working totally by yourself or your technician has a lot of stuff to do, just get the blood into buckets, close up the buckets, and do it post-op. That's not a big deal. You do what you can. I just want to get enough of this blood into the bag so I can show you that it like drips out the other side. Okay, so let's pretend that I filled up my bag. Now, remember that if you're using bags with anticoagulant or you're adding that in yourself, you do need to be wary of the syringe count. So this particular bag can accommodate around 240, 250 mils of blood. So that's the amount it's rated for. So just keep an eye on it and you will be just fine. So let's say I'm done with that. I'm just gonna close up my bag here. That way it's not gonna drip out that side. I'm just going to disconnect some of my equipment here. So you'll probably notice that on this bag I have 2 administration sets here. I have both a blood set and then I have an IV fluid set. So the IV fluid set is of course the side that I put the blood into the bag. I'm just gonna hang it because we don't need her anymore. And then the other side is the blood filtration set. So now at this point, all I would need to do is attach it to the patient's catheter and it starts dripping out again. And that's how you would do 2 different forms of open autotransfusion on surgical patients.